So let's get started. X-ray films, some of the normal anatomy of a cervical spine. Typically, there's a little bit of curvature to the cervical spine. There's different lines we look at if there's trauma or not, that the front of the bone should line up, the back of the bones should line up. The line that's back here is inside of these spinous processes. Okay, and we're just looking at everything that lines up and is appropriately arranged, that there's no injuries or subluxations or fractures, dislocations, things like that. In the front here, same sort of concepts. We're looking for the spine to line up, spacing between the bones is the same. Spinous processes are all in the midline. That there isn't a rotational issue where you'll see one spinous process sitting way over here. And the joints that are specific or relegated just to the cervical spine that are not located in the middle or lower back. They're called the joints of Luschka or uncinate processes back here. And this is actually a little bit of a joint at the corner of the disc space in the neck. The reason why that's important is that can cause problems with bone spurring and pinching the nerves that come out right at those locations. Okay. Kind of a close-up view of the dens or the C2 vertebrae, and this is C1 around it. You kind of see this cartoon that's over here, all right? C1 is basically just a big ring. There's not really a lot of vertebral body to it at all, and then there's the post of C2, and this is where the majority of motion comes between C1 and C2, so it's just like your thumb in a ring. It rotates on that post, so we have a lot of motion there. 50% of your neck's motion comes from that level. Why is this important? With cervical fusions, patients are always asking, how much motion am I going to lose? Well, 50% of the motion of the neck comes between the head and the first vertebrae, and 50% between the first and second vertebrae. So, if you have 50% of the first two vertebrae in your neck, you divide the rest up by what's left. You fuse one or two levels, you're going to lose maybe 10% of motion, not a whole lot. So they tend to do very well with that type of surgery. Lumbar spine, similar concepts. There's a little bit of curve to it. We're looking for the spacing. This is the front view, okay? The side view here, the spacing between the bones, the disc spaces, okay? You can kind of see that there's really not much disc space there, not much disc space there. That's also called degenerative disc disease. A little bit of bone spurring on the front, okay? And then the joints back here called facet joints, okay? And those are the articular processes or the way the bones move amongst one another. There's two facet joints, one disc space, kind of sets up a kind of a three-pronged structure of motion as far as the spine is concerned. You have a disc in front and then two joints in the back, okay? And then the spinous processes are in the back. I don't know if you guys can see that or not. These bones are sort of projecting out the back there. And those will be important for one of the procedures I'll show you that we've come to use to help minimize the amount of surgery or the scope of surgery that we do for doing a fusion, okay? This view is important because what we're looking for here, this is kind of like an owl. The eyes here, there's an ear coming out here, okay? There's the nose or beak coming down here, and there's another eye here, and then the ear here, okay? The reason why that's important, these are the pedicles, or the tubes of bone that the pedicle screws go into. Again, I'll show you that in the models where those are. And you're making sure that those line up, okay, and have a gradual progression as far as from medial to lateral. Okay, these are a little bit wider, obviously, than they are up here. Looking at these transverse processes, make sure there's not a fracture. Spinous processes line up as well, so there's not a shift or a subluxation in the spine. So all these things, it looks pretty simple as far as the alignment of an X-ray, but you're really looking for a lot of the nuances and changes. What you don't see here, and what I'm not talking about, is you don't see the disc space, right? You don't see the disc, you just see a space here. You don't see the nerves or anything in the spinal canal there, because you can't see them on X-ray. So that's the reason we get more distinctive or definitive imaging, such as MRIs. So why do we ever CT scan? Some cases MRIs and others. What's a CT myelogram? Why do we get that? Advantages, disadvantages of these studies, okay? So CT stands for computed tomography. It's an advantage. It has great bone detail, okay? Disadvantage is that it's a lot of radiation, actually. It's like 100 X-rays at once because the way that the CT scan works. Now, if you look at this machine, so you guys understand that. Do you guys know how a CT scan works? Has anybody ever gone over that as far as the actual technology? This tube or this donut that they go into, okay, both of these here, what there is in there is actually just an X-ray machine, okay, and that X-ray machine is on a wheel that goes around the patient, and what the machine does, it spins that X-ray machine around the patient's body while they're sitting in there, taking multiple X-rays from every different direction. Then the sensor that's on the other side of the X-ray, so this thing is spinning around like this, and keeps going around, where you have an emitter and a receiver over here as far as the X-rays, and then those signals of the radiation that gets picked up by the receiver gets sent to a computer. The computer then picks up the different densities and how much density there is on these different X-rays. And why that's important is if you take an x-ray through a spine, or you're taking an x-ray just like you see here on this previous image. Okay? There's bone here, there's no bone here. Okay? There's no bone here. When that x-ray is taken, now it changes a few degrees, takes another x-ray. Well, there's still going to be no bone here, and these bones are going to be taken at a different angle. Well, the computer interprets that and gives you a very clear picture of the bones with much more detail because it's many, many, many x-rays taken at one time, and the computer puts all that information together and generates an image for you. Okay, and you'll see what that looks like. Here's a CT scan. And then in addition to that part I forgot to tell you is it works like a bread slicer. So there's a vertical slices it's taking through you and then horizontal slices through you so you can get better details as far as looking at those fine cuts. So now you can see it, you can clearly see the bones very, very clear. They're not this hazy whitish fog that you see on an x-ray. You can actually make the actual distinct borders out. Obviously there's a big problem right here. But those are spinous processes that I showed you in the back, okay? You can make out a little bit of the soft tissue. This is the spinal canal, okay, through here. The spinal nerve roots are in here. Spinal cord ends right about here, okay? And then the disc spaces, you still get just kind of an idea that there's some stuff in there, but you really can't get a clear actual image of what's compared to what. Like, where does this disc space end? Well, it's there, back here. It's not here. It should be ending right here, so it's not as clear to look at the soft tissues, but it does give you a very clear look at the bone. This is a cross-section of this fracture. So this is this piece of bone that's shifted or pushed back into the canal. That's where it is inside the canal. This should be an open hole. Okay, so that's what's called a burst fracture because it literally, it's usually a compression fracture or compression force that bursts the bone. And so the part that's really worrisome is the part that goes posteriorly into the canal where the nerve roots are. Okay, so that's CT scan. All right. CT myelogram, which is basically an additional study or a procedure that's done with a CAT scan. They're basically injecting dye into that tube of fluid where the nerve roots are, okay? So it shows up on the CAT scan. So you get a little bit better picture of what the nerve roots look like in here because the dye will show up everywhere there's fluid, and where there isn't fluid, where the nerves are, you'll see structure there. So there's your bottom, your spinal cord comes to a point right there, and then down here is the strings of spaghetti that hang off of it that make up your spinal canal of the lumbar spine. All right. See the disc? So that's what you're kind of looking for there, something indenting the canal there. This is not the same CT scan, obviously, as the fracture. All right. Again, a couple issues that are disadvantages of this study. One is it's an injection, it's a spinal injection. You can get a CSF leak, you can get headaches, complications. That dye that's in there can irritate the nerves, and they can have a problem from that. Why do we get this? Well, if somebody has a pacemaker, has metal clips in their eye or aneurysmal clips in the brain, you can't get an MRI because it tends to move metal or causes pacemakers to no longer function. So you can't use an MRI, and you have to use something like this, which doesn't affect those issues. Do you guys know how the MRI works, by the way, as far as the technology of that too? With that magnetic field, okay, what it does is there's hydrogen atoms that are attached to all the different atoms or the molecules in our body. Well, the hydrogen atoms, the way they're attached to the molecule, they have certain angles of attachment. When you turn a magnet on, as powerful as these magnets are, those hydrogen atoms go into a certain alignment. Okay, then they shut the magnet off. Those hydrogen atoms then go back to where they were. When they do that, they actually release energy. And that MRI machine picks up that energy that's being released, and the computer once again interprets that information into an image. So that's how you get the pictures. So MRI kind of has a similar look to a CAT scan, but it's not radiation. Okay, typically it's a little deeper. Okay, it still has a little bit of a tube concept to it, but it's basically a large magnet coil around this hole that the patient goes into, and then from that magnet it gives you images. Okay, similar concepts, works like a bread slicer, horizontal, vertically, and gives you those images. The key with an MRI is that it, one, doesn't have radiation because it's a magnetic field. Two, is that it's looking for soft tissues, and it's very good at picking up water. And why that's important is when you have an injury, think of any injury you've had, you get swelling associated with that. Well, if you have a recent injury, an MRI can pick up the water or the swelling or edema in that area and tell you that something's just happened, whether it being old or new. Okay, so that's the very sensitive for acute trauma here. Okay, disadvantages, again, the pacemaker, aneurysmal clips, metal flakes in the eyes, things like that are a problem. All right, T1, T2, these are just different sequences and how they set up the MRI machine as far as showing you pictures. In this sequence, you see the fluid's dark, the spinal nerve roots and spinal cord are lighter. There's your discs, there's a herniation right there. That's a problem. Okay, that's a problem. And then over here in T2, you see the same sort of thing. But you can tell now, if you were to get a CAT scan on this, you can't see any of this material, and you cannot see that going on. So you can get a CAT scan, everything looks fine, but that's just not the real story there. All right. Here's the cross-sectional images now. Here's a nerve root on the, this is actually the right side over here, and the left is over here. So that's a disc herniation right there, pushing on the nerve root, getting squished right underneath here. Same thing over there. Okay, just different sequences, T1 and T2. All right, now do you see the difference between an MRI and a CAT scan, putting them side by side? So, typically we see in a lot of we get a lot of CAT scans we see. The ER tends to like to order CAT scans when patients have neurologic issues or back issues. And we're not really sure why they do that. I mean, obviously for fracture, that makes sense. The patient has a fracture here, there's a fracture up here, there's multiple fractures in this patient. So a CAT scan to look at the bone detail is appropriate, and getting an MRI, then you see that the nerve's getting pinched right there. Okay, gives you a much better look at that. But when patients come in with non-traumas that have leg pain, back and leg pain, a CAT scan's relatively useless because it's not going to show you what you need to see. Exposes the patient to radiation, and you got to get the MRI anyways, so it doesn't really help you a whole heck of a lot. The only time we really need to use CT scans is in trauma, looking at bone detail. When we see what the fracture looks like, where are these pieces of bone in preparations for surgery, or what do they need done as far as treatment's concerned. All right. Bone scan. Probably don't see a lot of this anymore. This is becoming pretty obsolete. We'll use bone scans occasionally for patients who can't get an MRI to look for an acute fracture. And CAT scans aren't real helpful if it's a crack through a bone, but it's not actually changed in shape. You can't really see it that well. So we'll get a bone scan to look for any increased activity in the body. So what that entails is basically injecting a dye, a radioactive dye, into the body. And then the bone cells, the ones that produce bone and make bone, preferentially drink up that fluid or that dye, and then you run a sensor over, kind of like a Geiger counter, to pick up the activity and see where it is. And then it shows you that there's an issue right there in the lumbar spine. This is sort of an inverted picture, okay, and then here too. But that's a bone scan. We don't use them a whole heck of a lot anymore. All right, back to anatomy. Spine motion segment versus spine segments. It's a nuance, but it's an important one. The spine segment is the bone, okay, and the spine motion segment's the bone, disc, and another bone into one unit. You have to have something moving in relation to something else in order to be a motion segment. One bone by itself doesn't move; it's just a piece of bone. Okay. There also includes, there's ligaments in between the spinous processes over these joints as well, on the front of the spine and on the back of the spine as well. So these soft tissues, these ligaments, are important because, one, they stabilize the spine. Two, they can be sources for pain, not necessarily a disc bulge that you see on an MRI the patient probably has had for many years, not necessarily a source for their pain complaints, but then also the facet joints as well. There can be pain coming from those facet joints as well. So a lot of different pain generators in the spine, and hence the reason that spinal surgery, you got to be very, very careful when you're recommending surgery for patients, because you got to make real sure where the patient's pain is coming from to make the diagnosis in order to treat them appropriately. All right, the disc. So this is a disc in cross-section of a cadaveric specimen, okay, fresh frozen, but this is the outer annulus, or the annulus fibrosus. Okay, there's two parts to it, but for all intents and purposes, it has pretty much the same function. And if you look like it has a very similar look to the rings of a tree, okay? And then the center gelatinous, or this jelly portion, the center portion, is where most of the weight bearing is done and most of the shock absorption is done for discs as far as the spine is concerned. Now, this center portion, you can tell, likely has more water content because it seems like it's more fluid, all right? When you lay down at night, the molecules that are in here, the proteoglycans, let me see if we have a picture, okay? The proteoglycans, or these molecules, okay, they're basically like little sponges, and they soak up water when you lay down at night and basically eliminate gravity, and your discs expand a little bit and they get pressurized to do their job the next day. This is why you have patients that go to bed at night and they wake up later in the night with more pain going down their leg when they have a herniation, because this thing gets pressurized, and if there's a herniation coming out the back here, it'll push more of that disc up against the nerve and cause it to put more pressure on it, and they'll complain of more pain at nighttime. All right. So that's predominantly type 1 collagen as far as annulus fibrosis. Nucleus pulposus, predominantly type 2. And then if you look at the fibers of the disc, you see how they're sort of transversely or obliquely oriented. So this will work well for flexion, extension, lateral bending. The thing that it will not work well for, or has a tendency to wear out, is think about those two bones turning on one another, twisting motion, okay? This is the least least well-tolerated motion as far as the spine is concerned. That's when most injuries come, usually with a twisting injury. All right. Again, that's those molecules I was talking about as far as the sponge-like material that drinks up water at nighttime and becomes a shock absorber for the next day. It's about 70% of the compressive force is maintained or taken care of by that nucleus. The annulus, laminate structure, basically maintains that nucleus, sort of the tough workhorse of the disc in maintaining its function. You guys have heard all these names before. You guys see these in reports. I mean, it's like alphabet soup of what's going on in discs. Okay, is it a protrusion? Is it a prolapse? Is it an extrusion? Is it a sequestration? What are you talking about, right? What does that mean? It's basically a continuum, a spectrum of what happens with these discs. You have a little bit of bulging disc, protrusion they'll call that, prolapse. You don't ever really see that so much anymore. You just see protrusion or extrusion. So the way to kind of get a clear handle on that, protrusion is when the annulus hasn't been ruptured itself. There's a bulging disc, the annulus is weakened and it's bulging, allowing some of that material to bulge back, but hasn't broken through. And then down here, the extrusion, it's now broken through and actually squirted out. So the jelly donut's popped. All right, you got jelly squirting out the back here. Then a piece can break off and kind of float down behind the vertebral bodies or go somewhere and push on the nerves further down than just where that disc is. Okay, that's what we call a sequestered disc. So that's what that means. Here's an extruded disc herniation. Okay, see how it's, the jelly's out of the donut for sure there? That patient's got a problem, okay? What happens with these herniations? Well, majority of the patients with disc herniations end up what we call a chemical. There's two parts of the equation when it comes to a disc herniation. There's chemical irritation of the nerve, okay? And then there's actual compression of the nerve or mechanical force or pinching of the nerve. Most of the time, it's a chemical irritation from this disc being here where the body is trying to dissolve it. The chemicals are causing all kinds of issues and flaring things up in there, and it hurts the nerve because it gets irritable and inflamed, all right? If it's a large enough disc herniation, like this one probably is, where it's enough to push the nerve, which is going right, you can kind of see it passing right through here. You guys see that? Okay, to pinch that nerve between the bone and the disc here. Okay, so you can get mechanical compression then. Then your epidurals won't work, physical therapy can be of some benefit, but it depends on how bad it is. But the most important thing there is it depends on whether or not they have motor weakness. Okay, most of these patients will come in with some form of pain, have some numbness, but when they get motor weakness, okay, when there's actual dysfunction of the muscles and the function as far as strength is concerned, that's a huge red flag, okay? That's a very bad sign, a bad prognosis if that nerve doesn't get decompressed. It means it's telling you I've got a problem, I'm dying here, okay? The reason why we get weakness is it's losing its blood supply from the amount of pressure that's going to the nerve or on the nerve from the disc. So that makes it obviously a big problem. You're gonna get back discomfort, sometimes not. The one that's always worrisome is when the patient has radicular pain, has sensory changes, all of a sudden those symptoms go away, but they still have the weakness. The reason why that's a problem is those fibers that are responsible for sensation have probably already died off. And so when you do surgery, you can get their strength back, but they may have some persistent numbness longer term. Okay, so that can be an issue. But motor weakness is a big red flag, and that's patients have a presentation such as that. You want to catch these patients as soon as possible, particularly with motor weakness, okay? I mean, ASAP. This isn't somebody that should be going to chiropractors. They shouldn't be going to a pain management doctor. They shouldn't be going to OC Health. They should be seen by a surgeon as soon as possible, okay? To get them their best outcome and get them through this with the least amount of deficits afterwards. As far as time frames go, if it's radicular pain and sensory changes, you can wait on those patients a little bit longer and see how they do. Typically about 85% of patients will do better, will do fine without surgical intervention. You just treat them with medications, anti-inflammatories, epidural injections, physical therapy, and do fine. The last 15% sometimes need surgery. It depends on whether they want it. It's up to them. So that's something they have to have. All right. So what does it look like? And you have the nerve roots as a sort of a cartoon of that. Here's a central disc herniation. Not pinching any of the nerves, okay? But over here when it's a little paracentral off midline, now it's pinching a nerve and causes a problem. The central ones, unless they're really huge, don't cause a lot of leg issues or nerve issues. They'll give you back pain. But unless it's a nerve problem, typically you don't want to recommend surgery for that. Okay, because they don't need it. Typically doesn't do well because they've got back pain already, and they're going to probably have more back pain from surgery on top of that. The idea of surgery is to get rid of that leg pain. All right. So what do the procedures look like? Okay, this is a laminotomy. I'll show you on this model kind of what this looks like. Again, these terms you hear, and you're kind of not real sure what they look like. Basically, if this is an image looking at this model straight down the canal where the nerves are, spinous process is on top, vertebral body in front, okay? You don't really see the vertebral body, just this arch where where the canal of nerves are, okay? Basically what you end up doing is making a little window on one side of the bone here to get to where the disc herniation is that's causing the problem. And on the right side, we don't just jab a knife in there like that. I hope you guys realize that. It's just a cartoon of how we do that, because you'd be out of practice pretty quick. So you're basically going to release the ligament. There's in between the bones here. This model doesn't show that. You'll see in the cadaver. There's a ligament in between these bones that basically covers the canal, okay? So you have to kind of release that ligament in order to move it out of the way to get a better vision or get some visualization inside the canal to look at those nerves, okay, and get them out of the way to get the piece of disc out. All right, so that's kind of what it looks like now with the actual nerve roots. This is the collection of nerve roots inside. Now that this basically remove the whole spinous process here for this picture. And you're basically taking a probe and cleaning out the disc material that's squirted out. We don't take out this much disc. This is just for sort of illustrative purposes, but that's what it looks like when it comes out. It looks like a piece of crab meat. And I'll show you some of that in the cadaver lab there too, as far as what that looks like. Spinal stenosis. All right, you guys probably see a lot of it, hear a lot of this on the MRI reports. Spinal stenosis typically is a chronic issue. It can be caused by an acute issue. For instance, patients have underlying narrowing of the nerves, but then have a disc herniation that puts things over the edge as far as pinching the nerves inside the canal. If it's large enough, can cause actually a problem that they didn't have prior to that, meaning that they might have some back pain but never any leg pain. So they have a herniation with underlying stenosis. They're obviously at a bigger risk of having a problem. Neurogenic claudication, what does that mean if you hear that term? What that means is when patients are standing or walking, okay, when they're weight bearing, the canal where the nerves are actually gets a little bit smaller. When they sit down, they flex forward, as you can see in this model. The bones tend to spread out a little more, so they get more room where the nerve roots are, and then their symptoms go away when they sit down. When they stand up, you see how they get closer together when you weight bear? So they get symptoms when they're standing and walking, but not when they're sitting or laying down, because it tends to alleviate that pressure. So that's what neurogenic claudication is. It means those nerves are getting pinched when they're upright. Lateral recess decompression. So this is somebody who has spinal stenosis in conjunction. This is not so much for a ruptured disc, but they have bone spurs that are growing. You do the laminectomy or that window into the spine there, but also have to take out these overgrown facet joints, which are the arthritic facet joints on either side. Okay? And then use a probe, make sure that the nerves are nice and free on the corners there. Instrumentation. This is that less invasive procedure. Instead of using pedicle screws, which I'll show you both, but we're starting to use the spinous process instrumentation, where the actual, this implant basically grabs on and kind of clamps these two spinous processes together with bone graft in between, so that the fusion happens between these bones that are projecting out the back of the spine. So that goes in between the spinous processes back here that keeps the bones from moving, but also helps them fuse together, so you don't have to open a much wider incision, bigger incision, move more muscles out of the way, cause more muscle damage to put in pedicle screws. All right. The benefit of that, there's an example of real-life incision right there, how much smaller they are. You know, typically, your fusion incisions are 4 to 6 inches. This is about 2 inches. So it's a much smaller, it's almost like the same size as a discectomy incision as far as getting the procedure done. You guys, spinalolisthesis, as far as you guys run that terminology a lot. So basically this means spinal slippage. So you see how this bone down here is slipped forward on the one below it because this bone is broken right through here, okay? If you look at the side view of this one, this is the bone that's, the vertebral body has this bone that kind of hangs down and catches on the next one below it. You see how this one's compromised? Well, that is no longer catching on the one below it, so it allows this bone to shift forward and the rest of the spine kind of goes with it, all right? Problem with that is twofold. You know, you lose this disc space, the hole where the nerve comes out becomes shrunk because this disc space gets worn out, and the nerve that comes out at that level can get pinched and they have more problems. They start having leg problems and leg symptoms. Different levels of spinalolisthesis. This is a grade 1 through grade 4. It's called the Myerding classification. It's just how bad that slip is. Typically, you're going to see grade 1 or 2. Grade 3 and grade 4 are very rare. Pretty rare that you're going to see it that bad. Well, you know what? That's a good question, actually. This usually happens at the end of the first decade of life, somewhere between the ages of 8 and 13, okay? And the patients have this, they end up getting a job as an iron worker, end up getting a job as a boiler maker, construction, whatever it is, and don't know they have this injury. All right, what ends up happening, for instance, I just treated a gentleman 4 weeks ago working on billboards. He goes up, hangs billboard signs up and down ladders like crazy, workaholic. Ended up taking a fall off one of the ladders because he just lost his grip and it falling was high winds that day. Ended up with horrible back pain and then eventually numbness going down both of his legs and getting worse with time. We get an x-ray when he came in the office. He had this same problem, but his was actually grade 2, which was shifted a little bit further. He actually had, so we treated him conservatively. He got a little bit better, was doing well, tried to go back to work and regular duties for a while. Did that for about 3 or 4 weeks, and then his symptoms got worse again to the point where he was starting to lose more function as far as his numbness and tingling was concerned. Brought him back to the office, took another x-ray, and repeated his MRI study, and his bone had actually shifted even more. So typically what happens in youth is this thing breaks. Instead of this bone healing like it should, there's a very poor blood supply in this area of the bone. So what ends up happening in here is you get scar tissue. Well, scar tissue is not as good as bone. It's not going to hold it as well. What happens over time is that bone, that scar tissue, stretches out, and now it starts to slide out of place. All right, and that's why you get that slippage there. And in his case, when he had that fall, he actually disrupted that scar tissue, and that bone was just sliding around in there. And then we got in the operating room and opened him up, and that bone was just, it was all over the place. I mean, that's an instance of the guy has a pre-existing condition, never had any issues with it. Now it's symptomatic because he had a fall and made it. Okay. If you look at the back of the bone here, okay, I'm giving you one vertebrae. It's this very narrow area right through here. Okay, if you guys can see that, kind of where the bone is the narrowest in the back of the spine, that's where that breaks and cracks. The lower portion of the back at L5 down here, where that is, gets a lot of this sort of extension force where it actually cracks through that, and that's where you get that fracture. You can't have it at any level in the spine. I would tell you, just based anecdotally and the research we have, 90 to 95% of them are L5. The rest of them are distributed. As you go up, the incidence drops. So you have 90% of it L5, maybe 5-8% of it L4, maybe 2% L3, and it's usually rare to see that above that as far as the incidence. So that's called an isthmic spondylolisthesis, a degenerative spondylolisthesis. Okay, is when the joint, let me do my pointer, these joints back here, okay, this is just like any joint, like your knee, your hip, your shoulder, anything like that, has the cartilage, that white, shiny stuff that provides a slippery surface and a cushion for the joint. Well, these joints in your back have the same thing. When that gets arthritic, that cushion and that cartilage disappears. So now, where this is supposed to be holding this bone still, that joint gets real sloppy, okay, gets real loose. And then that joint will allow that bone to shift forward on the one below it, okay, because that joint's not holding as well as it should. Because there's no fracture, so it's a different type of spondylolisthesis. That's a fractured spondylolisthesis, a chronic one. But that's the difference. And degenerative is much more common for the most part, typically with degeneration in time. You're not going to see a degenerative spondy typically until you're at minimum in 30s and 40s. But usually it's higher up than that. Yeah. So, all right, pedicle screws. All right, this is a picture, an x-ray of a pedicle screw. This is looking at that spine model from the back, okay? So this is that spinous process is looking at it right on end, okay? And then there's the joint hanging down here and the one over here, which is these structures hanging down right here and right here, okay? The pedicle screw goes right where this transverse process, okay, meets this facet joint, okay? Right, so if you follow that transverse process right to where it meets the rest of the bone, that's exactly where the pedicle screw goes in. And then depending on which level you're at, depends on which angle the screw goes in, whether it goes in straight, if it goes down a little bit, or if you angle it up, depending on what the orientation of the bone is in the spine. Okay, but that's how we do as far as using a probe. That would be for fusion. Yeah, this would be pedicle screws where you'd put 2 screws on each side. So there'll be a screw right where this little awl is going in, one here. There's a rod that will connect those two, and then a screw here, and a rod that will connect those two. All right. So now this is a disc herniation in a cervical spine. Okay, see that back there pushing toward where the spinal cord is here. So that's a big problem there, right? Well, again, we're talking about the diagnosis determines the treatment, particularly even with surgery. So there's different procedures in the neck, right? You can do an anterior cervical discectomy infusion or ACDF. You may have heard that. There's posterior decompression infusion. Well, you don't want to go posterior on this patient, okay, because the problem is in front. This is the tongue right here, is the front of the neck. Here's the back of the neck here, spinous process, spinal cord, and discs. Okay, the discs are in front of the spine. So the problem is you can't go from the back to get this thing out of here. You don't want to be moving or retracting the spinal cord out of the way. The important point there is the spinal cord is part of the brain. It's brain-like tissue. The nerves that come off the spinal cord are not, okay? They were called postsynaptic fibers, which means they're much more resilient, they're much more durable, and you can move them out of the way without hurting them. They're more like the nerves in your periphery, in your arms and legs, the peripheral nerves. They're much more resilient and resistant to injury, okay? So if this is in the lumbar spine, there's just a collection or a tube of fluid filled with spaghetti strings, okay, or the cauda which you can move to the side and take out the piece of disc. In the cervical spine, there's no spaghetti string, there's just solid cords. You put a retractor on and start pulling on it, the patient may not be moving when they wake up, all right, which is not good, obviously. So we typically approach this from the front. So what we do is take out the disc material from the front through a small incision on the neck. And what's beneficial about that is that there's no muscles to cut here. All you have to cut is the skin, and then the way the muscles are oriented in the neck, you just spread them apart, so you don't have to cut anything, and the spine's right there. All right, and then you basically clean out the disc, and then if you don't put anything in here, like we put a chunk of bone or a different type of spacer, then this bone's going to collapse on the one below it, and then where the hole where the nerves are, see in the corner here, these two bones come close together, you're going to pinch the nerve that's coming out the side, so you have to restabilize the spine to make sure its function maintains.
How often do you see people with herniated discs have that resolve on its own?
Again, about 80 to 85%, it's 80 to 90, somewhere in that ballpark. You give them a chance to recover, depending how bad their symptoms are.
Like with the weakness and everything included in it?
If they have weakness, that's the big changer. If they come and they present and they have weakness, they need surgery. Okay. Why is that important, and why do we say that? These fibers that come out of the spine, okay, at each one of the levels here, okay, I'll put a picture of. Okay, this nerve that comes out, all right, this nerve has multiple fibers inside of it, or multiple functions. Some of it's responsible for sensory, some of it's responsible for where your extremity is in space. We call it proprioception. Some of it's responsible to move the muscles, contract the muscles. Some vascular outflow issues as far as maintaining blood flow and things like that as well. Because you'll have some patients will come and be like, my foot's swollen, where they got a disc herniation pinching the nerve and it's changing the vascularity down there. With that nerve being pinched, those fibers that are responsible for moving the muscles are very, very resilient fibers and very kind of hardy. The ones that are responsible for sensation are kind of wimpy. All right? It doesn't take much to knock them off and give you some numbness and some tingling. If they have weakness, that means that nerve has to have pressure on it, or it has to be getting squeezed. You're not going to lose strength from the chemical irritation side of the equation. It has to be mechanical compression. So nothing's going to fix mechanical compression other than going in and mechanically decompressing it to get the pressure off that nerve so they can get that function. There's a burr and sort of light instruments that we use to get the disc out and clean this out. Maybe they used to use this, but I think just from a cartoon standpoint. And then you put in the bone graft or the spacer in here to stabilize the spine. But the drill hole doesn't look like that.
How often do you use spacers versus bone?
What's the question again? I'm sorry.
How often do you use what you're calling spacers versus bone?
I pretty much use spacers all the time now. And the reason why is because just based on what works in everybody's hands, okay? What I've seen with bone is that bone subsides, bone breaks, and bone can shift out of place pretty well. Most importantly is the subsidence, which means that if you use a bone graft in between here, okay, what we see a lot of is that bone itself will collapse and even collapse into the end plate. One, because the bone grafts are usually pretty small entities of bone, and two, the bone itself is not a sort of immobile object. The body can break that down. Okay, and it can cause it to subside and then the bones to collapse together and have a failure of the surgery, or we need a failure of union and need to be revised. And you'll see that subsidence when these two bones come close together much more readily with bone when you use a bone plug in there as opposed to a spacer. The spacer will not give, it just won't. It'll stay and maintain that height without fail. So that's the reason I tend to use spacers. Other docs may like to use bone because it works better in their hands.
Where do you get that away with the artificial disc?
Sorry. I'm sorry?
Artificial disc. That used to be a big controversy probably 20 years ago when they started using them, because I was in Tennessee.
Okay.
And they were saying they didn't work, and some doctors were saying they did work, the artificial disc, and I haven't heard anything about it in some time.
For good reason, though. It depends on where. In the lumbar spine, which is where they were really pushing artificial discs, because that's where most disc problems and a lot of the fusion stuff is going on, and you have problems with adjacent segment degeneration more in the lumbar spine because of the amount of weight that's going through the lumbar spine. So that was the big push for artificial disc replacements. Well, the disc that came out, the Charité, was the first one that came out, and it's got to be 2006 or so when it first started coming out. They had a lot of complications once it was released to be used, meaning dislodgement, vascular injuries. They had a 1% death rate from that surgery, which is astronomically high for an elective procedure. 1% death rate is what you see typically in like open heart surgery. So 1 out of 100 people die. So if you have patients who went in for a lumbar disc replacement, 1 out of 100 were dying from it, which is a big problem. The reason why that was that, one, the implant wasn't designed very well. It was sliding out of place and getting dislodged. 2, getting back in there is very, very difficult. And now we have research that's shown the longer-term follow-up from those patients. There's no statistical difference between how they do long-term versus somebody who's had a fusion at 5 years out. So there's really not been a lot of benefit to the lumbar spine at this point. I think it's really on the back burner again, and they're back to the drawing board for the lower back. Now, the cervical spine, different entity. Much less force going through there. The newer implants are actually much better. I think there's a little bit brighter future for the cervical spine as far as doing a disc replacement as opposed to a fusion. The issue is we don't have better success rates with the artificial disc replacements. The pain scores are no different. Patients do just as well. Down the road, probably with adjacent segment degeneration, there may be a difference, but the studies we have to this date have shown there is no difference between the two as yet. So 2 things are still going to have to happen. 1, the implants are going to continue to have to get better, and 2, the results are going to have to show a clear distinction and difference of maintaining the motion, all right, as far as there being a benefit.
Now, what about fusion failure and repeat surgery? At least what I had heard before was that the scar tissue forms, and
Correct.
You can't repeat an anterior procedure.
In the cervical spine, or yeah, no, actually you can. As far as like, let's say you had a patient who had a 1-level fusion. Let me see if I have a picture of one. There you go. So this patient's had a 1-level fusion done. There's a bone graft that's put in there. Okay, let's say that's fused, and now this level has a problem. You can go back in there. It's a little more technically demanding when you're going through scar tissue, but if you're trained to do it, you can do it and do it pretty easily in that regard. It's just a matter of. It depends. Usually you'll take it out. The majority of the time you'll take it out. What you end up doing is either doing 1 plate up here. Personally, if I'm going to redo this, I'm going to take this out if I need to do this one. And it's almost always the level above in the cervical spine. It's next to unheard of to have the level below it be a problem. It's just where the responsibility is taken up with the fusion, it's usually the level above. So anyways, when I redo this, I would put the spacer in here, or the bone, okay? And then I would put a plate across the whole thing here, okay? And the reason why I would do that is you have a stiff segment here, and then you have a new fusion you're trying to do here. Well, there's going to be a lot more stress on your new fusion because you have a longer lever arm down here that doesn't move. So I would just plate both levels for extra added fixation because it's not going to cause any problems. And actually secure them to have a better outcome.
When you a couple slides ago, the disc herniation was poking out to the,
Mm-hmm.
and you were going in from the front, and you were going to suck it out from the back.
Nope, from the front.
Oh, I mean from the front. How do you know you got it out from the back? Do you watch?
How do you do what?
How do you know you got it? How do you know you suck it out from the front, but you can't? I mean from the front, but you can't see the back.
Well, you can see. So I'll show you actually up on the model here too. When you're in here, so what you end up doing is you make an incision, you're cleaning out this disc space. There's little pins we'll put in this bone, a pin in this bone that kind of stick up through the wound. And then you'll spread those 2 pins apart and actually open this up wider so you can actually see in there. And you have a microscope or microscopic lenses on. And you're looking back here, cleaning this stuff out. And part of the process of the surgery is you actually see this corner of bone that's kind of sticking out right here. Okay, that gets cleaned off. This corner of bone right here gets cleaned off as well. So you end up with a pretty decent window to see what's going on or to get that disc out of there. And then see the spinal cord come back towards you.
See the spinal cord, the edge, okay.
Yep.
Cool.
Yep. Yeah, you clean all that off until you're at the spinal cord, and then you see that float back towards you. As you're cleaning this disc out and this material comes off and you're cleaning the soft tissue away, and you get done actually in that, when you look down, you're looking at that crevice. you'll see the dura, or that tube of fluid that holds the spinal fluid and the cords inside. You'll see the tube of fluid actually balloon up into your crevice because it's been decompressed. It has a little bit of a bulging to it, which knows you know you have it then. And the dura in there is actually light blue, so you can tell that it's not disc, and that's how you know the difference between the dural tube and the actual disc material or the ligaments.
Too tough and strong, or is it, are you afraid you're gonna nick it?
Yeah, you got to be careful. You got to be careful. It's not, I mean, you can't just brush it and it tears open and falls apart. But if you pinch it or bite it or put a hook into it, I mean, you can tear it. Think of it just like a water balloon. It's very similar. I would tell you it's probably in the vicinity of what rubber is in that regard, like a water balloon. So you can imagine just grabbing that or pinching it, it's going to pop the balloon. Then you got water coming out, then it's a problem, major problem.
For the spacer material, if you're not using bone,
Mhm.
is it organic or synthetic?
It's synthetic. It's a polymer. It's like a plastic. It's like a plastic, but it's filled with their bone, and that's one of the reasons why. No, I forgot to mention this. Bone versus a spacer. The reason why I also like to use a spacer is because I use their bone. Remember I was telling you about these corners I take off? Okay, well, when you take those off with the instruments we have, either it's a little burr or like a little Dremel tool, or these little biting instruments called kerrisons, I save that bone in a little cup on the back, so that when I go to put the spacer in, which is what looks like this, okay, this little spacer, I fill that with their bone, okay? And the reason why I like that, it's the best bone graft there is because it's theirs, all right, as far as them recognizing and them healing it. Now, you're putting allograft in there, which is what this is. Okay, this is a cadaver bone. Okay, and there are times, and it's not infrequent, that the body won't take that. It won't take because it's foreign bone to it. It's not all the time, it's pretty rare, but I personally think it's a higher incidence for that reason than the patient's own bone being in there.
How do you go in and burn off those pieces off the above and below vertebrae without touching the spinal cord?
Very carefully. Very carefully. Yeah. Yeah, you get used to doing it. And the technique or the concept is, if you look at this, okay, what you end up doing is you see this bone spurts on front. The burr, you basically take a little sleeve of this underside of the bone here, a little sleeve of this bone too. And so you keep burring this back far enough until you have a little ledge right here, okay? So you'll see you kind of burred all this off, you burred this off, and then you have a little ledge here, okay? And you know how far deep your back is, you've done a million of these, right? So then what you do is you have a special instrument that goes and hooks underneath the corner here, and then you have a really small biting instrument, a kerrison, that has a little foot plate, and I'll show it to you up here, that you end up biting off that little corner, okay? But you gotta make sure you don't burr down too far, obviously, because you got problems. So that's always the stressful portion of these cases. If you're back there burring, it's like, you're burring next to the spinal cord. It's one of those things you can just take your time and, no rush, that type of thing. Make sure nobody's bumping the table or any issues like that. But you try to be real safe about not getting too close to it. So it takes training. So that's the little plate. Looks about the size of a postage stamp, and that's about the size. You'll see it up here.
You have a multi-level situation going on. At what point do you say, it's not going to help? Like, would you say a 3-level fusion?
For the neck?
Terrible success rate?
It boils down to how bad their symptoms are and what again, that diagnosis. The diagnosis will dictate what you recommend as far as surgery goes. For instance, if somebody has neck pain, I'm not recommending surgery ever really for that. I mean, it's next to unheard of unless they have instability or something bad going on. It has to be spinal cord or nerve root compression, pain that's just not getting better with conservative means. If there's weakness, those types of issues, or progression of numbness and tingling, that type of thing, losing function. Then it really boils down to what's going on in the spine. Is it multiple disc herniations that are causing problems on different nerves, and how bad their symptoms are.
What levels you'll see?
I don't have my iPad in here. I had a gentleman that had a swan neck deformity. So basically, instead of his spine being curved like this, it actually went forward in a bend like this, and then kind of came back up. And he had severe spinal cord compression. Was walking like somebody who's really stiff and rigid. Like you see patients with cerebral palsy have that spastic kind of gait. He had developed that from this problem in his neck, and I actually had to fuse him from C2 all the way down to T2. So it was his entire spine, front and back, to reconstruct his spine to get the pressure of the spinal cord, but to reorient the orientation or the alignment of his spine. to get through that. But and he's like, I can't live like this. He goes, I'd rather be dead 100 times than live like this, because he's losing function. He can't do anything. He's like, this isn't life. And he was in agony. What does that mean? Tight, okay.
Did he do well?
He did. He actually had a heck of a post-op course. He had to be intubated, had a trach tube for a while. He had to have a feeding tube for about, he was in the hospital for about a good 2 weeks, went to rehab. At about 3 months, he was up walking around doing pretty good.
Result of an injury?
Yeah. No, just degeneration and really bad genetics, I think, to some extent, unfortunately. Posterior spine, we end up opening it up from the back, kind of not like we take the disc off, but it ends up taking off these spinous processes, similar to what we do in the lumbar spine, to open up the canal and get the pressure off the spinal cord. Kind of is approached very similar to what we do in the lumbar spine, so we won't spend a lot of time. You're taking off the lamina on the back, I'll show you what that looks like, and then the spinal cord compression, getting it opened back up so there's plenty of room for it. All right.
Back on the 3-level laminectomy, I've got a guy that just got UR approved for that. We didn't think it had passed, but it did. So how do you protect the spine when you've exposed 3 levels? And
Great question. We get that all the time.
what's to prevent the spine from becoming unstable?
Well, that's when you need to do a fusion. The fusion portion of it keeps it from getting unstable.
Yeah, but I'm seeing 3-level laminectomies without fusion.
It would depend on the orientation and the alignment of the spine. My recommendation, the incidence of having post-laminectomy kyphosis, which means that you've done this laminectomy, and now that you took off the,
And it starts to twist.
it ends up, you take off these lamina, which there's ligaments holding the spine as well as the muscular attachments. Now you've taken 3 of these off. That segment of bone no longer has anything holding on it. What you'll end up seeing is the neck start to do this, okay? And over a period of the next few years, it's very, very high incidence of that. So I typically don't do cervical laminectomies without a fusion, just because you know what's coming down the road for the patient. And then it's a big problem, because now you've got to go into there where there's scar tissue, and it's a big wad of scar. The spinal cord's in that wad of scar. You've got to get through that and out to these bones to do a fusion to fix them, or try to do something anteriorly to fix it. So it's a real risky procedure to kind of reconstruct or
Would it be the
recover
same
from that.
for the lumbar?
Not for the lumbar. Lumbar spine is much closer together, and the orientation is typically in lumbar lordosis. And the way we do the decompressions now, we rarely take off the lamina completely. Usually we're just doing localized decompressions in between those spinous processes and cleaning out the bone spurs, but leaving those spinous processes in place for those attachments to hold the spine in place. So we try to avoid that. So that's with the laminectomy. Then we'll do a fusion, which is where you see the screws and rods. Very similar to pedicle screws. They're just a version of it for the neck. Okay. There's an example of a patient who has epidural hematoma. That's these kind of looks like this bubbles in here, this white fluid that's in here. It's pushing on the spinal cord. Who was on Coumadin, had an injury in it with an epidural hematoma. This is an emergency. So you take them, decompress them, and fuse them at those levels to get the pressure off the spinal cord. All right, and that's what that looks like afterwards. All right. How are we doing on time?